Let's talk SCUBA for ENTs, but mostly for ears, because that's the most important of ENT. Don't tell my rhinology program director I said that. So this is Dan and I. Dan is here with us in spirit and potentially at some point soon. We are both divers, both got into this for the love of the game. And this is Dan back in the day with some of y'all. So these are our acknowledgements, and we have nothing to disclose. So we're going to go over a pretty broad range of information today. We're going to start with a 30,000-foot view of what diving entails and the relevant physiology, which, full disclosure, does involve some physics. Next, we'll consider the pathophysiologic mechanisms at play in diving injuries, as well as the related strategies that we can give patients to prevent injury in the first place. We're going to cover the diagnostic approaches, as well as the acute and long-term management of patients who have suffered diving injuries. And finally, we'll take an evidence-based look at which patients can safely get in the water and which are better suited to snorkeling or staying on the boat. Danny, in now?
I'm in.
Good to see you.
Hello, everybody. That was painful.
Finally.
But, all right, you know, it is what it is. I got a foot of snow here in Connecticut. I have kids in the background, so we'll see how this goes. Okay, so thank you for joining us again, and sorry we're a little bit delayed, but I think we'll be well within our time. So we wanted to talk a little bit about this topic because even in Connecticut, I see patients who dive, and certainly on the coast where you guys are, you're going to see a lot more of this than I do. But it's real world, and if you're doing any ear medicine at all, you're going to see a lot of this. And if you have an interest in this, there's a really unmet need for care for these patients. So, you know, the distribution of ear trauma or trauma during scuba diving is predominantly otologic in nature, and that's shown by this data here. This is a really common problem, whether you live in the Midwest around the Great Lakes or you're on the coast or in Connecticut. We want to talk a little bit about some of the equipment because the equipment is pertinent to the discussion. And so basically, let's review some of the basic equipment. So this is the mask. We're all familiar with this. You can see that the nose is enclosed. So the nose is enclosed with the eyes, which is an important possibility. This is the standard buoyancy control device. It has a couple components. The vest, which holds the tank. There's a regulator, which is the mouthpiece, and then a backup regulator for emergencies. And also has a depth gauge.
All right, so let's go over some of the critical terms. So middle ear barotrauma, which is also known sometimes in the diving world as barotitis media, is the single most common diving-related medical problem. It's the result of a failure to equalize middle ear pressure compared to the outer and inner ear. Depending on the gradient of the pressure differential, the imbalance can be referred to as either middle ear squeeze or reverse middle ear squeeze. Middle ear squeeze occurring during descent when you're not auto-insufflating sufficiently. The TM bulges inward, and the pressure differential, as you know, can be quite uncomfortable, with reverse middle ear squeeze being the inverse and occurring on ascent with the TM bulging outward. Inner ear barotrauma similarly results from a pressure differential between the middle and inner ear spaces. As pressure is transmitted to the inner ear space, there can be tears or bleeds affecting the round or oval windows, Reisner's membrane, the tectorial membrane, or the basilar membrane. These almost always involve the cochlea when they do occur, and more often than not, they involve the vestibular system as well. Decompression sickness, which is colloquially known as the bends, is the result of free nitrogen bubbles in the bloodstream. When the inner ear is involved, which is a little less than 20% of the time, the term inner ear decompression sickness is used. When this does happen, it's most commonly unilateral, and typically it occurs when a diver has spent at least 20 minutes at a depth of 10 to 15 meters, and it's much more common if the diver skips safety stops.
Alternobaric vertigo is also known as pressure differential vertigo. This is usually a self-limited process that's short-lived, and it's very common in divers. And we see this with patients who have difficulty equalizing their ears while they dive. I think you can think of this as something we see probably even with asymmetric eustachian tube dysfunction, where patients just feel slightly off. So this is to a greater degree when you're diving, you'll see this very common phenomenon. A couple other terms that divers utilize. One is a safety stop. This is a stop that's usually occurring about 3 to 4 meters. And this is allowing for nitrogen clearance to take place on ascent. Divers use a dive table or a dive computer to calculate what's safe for times and to avoid decompression sickness. And then nitrogen narcosis is also something that we hear about, altered mental status, which can occur at extreme depths, usually over 100 feet, something that typical, shallow water divers with typical certifications do not experience classically.
All right, now on to the basic science. So the first law that we're going to look at is Boyle's. So this tells us that as the pressure on a gas changes, the volume changes inversely proportional. So as a diver descends, the external pressure exerted by the water increase and the volume of all gases in closed spaces decreases, such as in the middle ear when the patient can't equalize. The opposite occurs on ascent. All right, so this is a graphic that illustrates the relationship between gas volume, pressure, and depth. And these numbers are what is actually experienced by divers. So the greatest volume change occurs within the first several meters from the surface. At sea level, atmospheric pressure is 760 torr, or 1 atm. And this increases by 760 torr for each 10-meter interval the patient descends below the surface of the water. For comparison, commercial airplane cabins are typically pressurized to between 560 and 600 torr, leading to about a 200 torr or less pressure change during the entire process of takeoff or landing. While that occurs usually over a little bit of time when you're on an airplane, you get that same pressure differential within only the first 2 to 3 meters when you're diving. Now, the second equation we have to look at is Henry's law, which is not as complex as it looks. So P is pressure, C is solubility, and KH is a gas-specific constant. So what does this really tell us? Well, we can see that the amount of gas dissolved into solution, in this case the bloodstream, is directly related to the ambient pressure. So on descent, as pressure goes up and the amount of gas dissolved in the bloodstream increases, the deeper the dive, the higher the ambient pressure, as we just demonstrated, and therefore the greater the amount of nitrogen dissolved in the blood. Notably, you can have elevated nitrogen levels dissolved in the bloodstream for a short period of time that is physiologically inconsequential. As a matter of physics, though, all of the excess nitrogen and any other gases for that matter that were dissolved in the bloodstream at depth must be released upon ascent when returning to surface levels of pressure. So as the pressure decreases on ascent, inert nitrogen bubbles precipitate out of solution and into the bloodstream. So why doesn't every diver get the bends every time then, if they all have these nitrogen bubbles free floating in the bloodstream? So the key here is that at small volumes, the blood can filter out microscopic venous gas bubbles rather easily. It's the same reason why if you get a little bit of line in the, or air in the IV line, that we're not giving all these patients strokes right off the bat. As long as it's not a huge amount of air, you can filter those out really rather easily. So when divers make safety stops based on the depth characteristics of the dive, we prolong this process of nitrogen bubbles precipitating out, which limits both the volume of nitrogen as well as the average bubble size. That allows divers the opportunity to exhale the gas safely. Conversely, when you ascend too rapidly, the nitrogen precipitates out all at once, and you're not able to clear the gas before emboli form. So how does trauma actually occur? Let's start with barotrauma. So barotrauma occurs as a result of gas expansion or compression in a closed system. There are three key potential closed spaces to consider: the lungs, the sinuses, and the ears. So the lungs are only a closed space when patients hold their breath. Because of this, it's one of the number one rules of diving is you never hold your breath because you can get pulmonary barotrauma. As long as you're continually breathing in and out, even with pressure changes, the lungs aren't negatively affected because it approximates an open system. Sinus pressure only occurs if there's air in the sinuses and the ostia are blocked by inflamed mucosa, polyps, a mass. For the middle ear space, all right, this is really where the bread and butter of diving injuries occur. So if you have a failure to equalize via the eustachian tube, then you get a pressure differential with the middle ear as compared to both the outer and the inner ear. So during descent, the TM will retract and blood or fluid may extravasate into the middle ear in response to the vacuum created. The tympanic membrane can then rupture depending on its fragility, as well as the speed and depth of descent. All right, so this is a schematic of the external, middle, and inner ear. Although the external auditory canal and middle ear are naturally air-containing spaces, the inner ear is filled with non-compressible fluid. This means that any pressure waves that propagate across the tympanic membrane and along the acicular chain will transmit to the inner ear and potentially damage the inner ear membranes. This is also true of pressure waves transmitted via the cochlear aqueduct. If rupture occurs, it will preferentially affect the round window over the oval window. All right, so let's look a little bit more closely at the relationship between the subarachnoid space and the inner ear. Specifically, CSF communicates freely with the perilymphatic spaces of the inner ear via the cochlear aqueduct. Okay, so why is this important in diving? Well, one of the most tried and true techniques used to auto-insufflate, whether that's on land, in an airplane, underwater, is the Valsalva. At sea level or higher, that's the dominant effect as relates to ear physiology. We have to consider, though, that there's other physiology involved in a Valsalva, which becomes particularly salient underwater. In addition to temporarily opening the eustachian tube, a forceful Valsalva also causes an increase in intrathoracic pressure, which decreases venous return. As a result of this, intracranial pressure increases because cardiac output to the brain is increased and CSF drainage and reabsorption are impaired. Because the subarachnoid space and the perilymphatic spaces in the inner ear are connected, a Valsalva leads to an increase in inner ear pressure. The end result is that a Valsalva can cause a sudden increase in inner ear pressure that can damage the round and oval windows. If any of you expected to have gotten a lecture in cardiac physiology during your house clinic fellowship, there you go. You can check that box off. All right, so rupture of the round and oval window membranes in either direction can lead to a perilymphatic fistula. So once this occurs, air bubbles can enter the perilymph. When the patient ascends to the surface, there's a subsequent expansion within the scala vestibuli or scala tympani, depending on whether the tear is at the round or oval window, respectively. This can cause intracochlear membrane tears. Notably, pressure gradients as small as 115 torr are sufficient to rupture the round window membrane. Intracochlear membrane tears can present as a sensory neural hearing loss at isolated frequencies specific to the site of the tear, or it can cause intracochlear hemorrhage with more diffuse hearing loss. Intracochlear membrane tears can result in direct damage to the organ of Corti, as well as damage secondary to mixing of perilymph and endolymph. In terms of patterns, so cochlear hemorrhage is likely to cause a flat sensory neural hearing loss, and this can partially or completely resolve as the blood is reabsorbed. Barotrauma, when it does occur, tends to involve the outer hair cells more frequently than inner hair cells. Tympanic membrane perforation is acutely problematic for a diver because you get caloric irritation. Typically, divers are going to have water in their ear canals, but that caloric stimulation isn't a problem because you have a symmetric vestibular response that negates the effect when they're both involved equally. When you have a tympanic membrane tear, though, the response is asymmetric and can induce vertigo and vomiting. This is a big problem because, as Dan showed with the regulator, divers are obligate mouth breathers. So while you could theoretically take the regulator out of your mouth, vomit, put it back in and breathe, that's obviously not a situation any patient wants to find themselves in, particularly when they're, meters underwater. This does tend to resolve as the water temperature in the middle ear space warms to body temperature, though. All right, now we're going to shift the focus onto the middle ear and the eustachian tube. This is a schematic of the external, middle, and inner ear spaces. Let's break this up into some more easily digestible pieces, though. So in a normal functioning ear, pressure is equal in all three spaces, which at sea level is 760 torr or 1 atm. As we all know, equalization of the middle ear space is predicated on eustachian tube function. On descent, this is predominantly an active process where we have to push air into the middle ear space to counteract the added pressure on the tympanic membrane from the water, as we see in this next slide. So after descending 0.8 meters without middle ear equalization, the middle ear pressure remains at 760 torr, whereas the outer and inner ear are each at 820 torr at this point. With a pressure differential of 60 torr, fullness and pain typically occur and the eustachian tube becomes blocked. I really want to point out this is less than 1 meter. So this really occurs very early on. And it's why we tell people to start equalizing before they descend, because otherwise people will start descending, wait till they feel pain, and they're already way behind the 8 ball. So let's see what happens if our diver decides to tough it out and descend further without equalizing first. So with a continued descent to just 1.2 meters without any middle ear equalization, the differential increases to approximately 90 torr. At this point, the eustachian tube becomes blocked and actually locks due to the pressure differential and resulting edema. So at this point, it can be nearly impossible to open voluntarily. The strain on the tympanic membrane is often quite painful at this pressure differential. It only gets worse as it increases. The mucosal congestion and edema start to take place, but you're not really seeing structural damage at this point per se. All right, now we're going to break into all too common scenarios that can occur from here. So first, we'll see what happens when our diver attempts to auto-insufflate using a forced Valsalva. As we just reviewed, the Valsalva increases the intracranial pressure and thus the inner ear pressure. This differential with the middle ear can then lead to a perilymphatic fistula, most commonly via the round window. Alternatively, continued descent without middle ear equalization will lead to middle ear effusion, hemorrhage, or tympanic membrane rupture. Equalization is less of an issue during descent, as equalization of the middle ear space is more passive, as the relative positive pressure in the middle ear causes gas to escape through the eustachian tube. Difficulty with equalizing on ascent is often secondary to barotrauma and resultant inflammation that occurred during descent. With sequential dives, patients may notice worsening eustachian tube function as microtrauma causes inflammation of the eustachian tube. Additionally, the majority of instances of Alternobaric vertigo occur during ascent. This is supported by evidence in animal models showing that vestibular function is more affected by decreases in middle ear pressure than by increases.
Now let's look at the external ear canal. So normally this is an open system, so there's no difficulty. However, if you had a case of, say, significant cerumen, otitis externa, large exostoses obliterating the ear canal, or maybe putting in earplugs or headphones, you could have a problem where you'd have trauma within the ear canal, and that can also be transmitted to the middle ear space or the inner ear. So typically, headphones or earplugs during diving are usually avoided if possible.
As an air-filled space, the sinuses are another potential site for barotrauma if the ostia blockage is sufficiently severe. It occurs twice as often during descent as during ascent, and it typically localizes to the frontal sinus and almost universally manifests as pain alone, although there are case reports of divers descending despite mounting pain and inducing more serious sequelae, including orbital hemorrhage and pneumocephalus, as we can see here, in a diver who suffered from emphysema of the sella turcica. Rarely, surgical emphysema can occur wherein a blowout of the ethmoid cells leads to a crack in the lamina pepratia, allowing air to track into the orbit. Swelling within the maxillary sinus can put pressure on the infraorbital nerve or the posterior superior alveolar nerve, leading to paresthesias. Although the dive mask is also an air-containing space, the nose is universally included. Because of this, even small amounts of nasal airflow are enough to equilibrate pressures. Though rare, in the presence of a dehiscent facial nerve, increased middle ear pressures can also lead to facial nerve baroparesis that can be temporary or permanent. All right, now we're going to look a little bit more closely at why inert nitrogen bubbles precipitating out of solution with ambient pressure decreases causes trouble. So first, we're going to dispel the myth that this only is a problem for deep professional divers that use unique gas admixtures. It can, and it does affect compressed air recreational divers, even when depth and decompression protocols are followed. So decompression sickness has effects on multiple end organ systems, but we're just going to focus on the inner ear for the purposes of this talk. So there are multiple theories regarding the pathophysiology. The most widely accepted at this point involves venous gas emboli traveling through a right to left cardiac shunt with subsequent occlusion of the labyrinthine artery. This is also the prevailing theory for non-otologic manifestations of decompression sickness. This theory is further supported by the predilection for inner ear decompression sickness to affect the right ear over the left by a factor of nearly 4 to 1, since any embolus entering the aorta will pass by the branch point for the right vertebral artery before passing the branch point for the left. Right to left shunts, such as in a patent foramen ovale, are relatively common and are found in up to 25% of the population. Multiple studies have demonstrated an increased incidence of major patent foramen ovale in patients who have had inner ear decompression sickness. Other theories include bubble formation within the otic capsule osteoclast and gas supersaturation in the inner ear spaces, potentially leading to vascular injury. It's believed that the vestibular system is more commonly affected than the cochlea, or the rest of the brain for that matter, because of washout times, which are based on blood supply and tissue volumes.
Okay, so preventing injury is a critical component of counseling of our patients. And the tenet of scuba diving is to plan the dive and to dive the plan. And a major component of that is understanding how to equilibrate your ears. And so there's a number of different maneuvers that one can know about. We've heard about the Valsalva, which is widely known to improve function by pinching the nostrils and attempting to blow air out of the nose. The second was the Frenzel, which should be discussed. That was developed for fighter pilots in World War II, and that involves tightly adducting the vocal folds with the nostrils pinched in an effort to make a k sound. This causes the thyroid cartilage to rise in conjunction with the base of tongue, which pistons air into the nasopharynx to open the eustachian tubes. The Toynbee combines pinching of the nostrils while swallowing, which also can be effective. There's a fourth method called the Lowry technique, which requires practice, but is also effective. It can be done by a combination of the Valsalva performed with initiation of swallowing. Additionally, another pearl is that a patient underwater can turn their neck upwards and allow the eustachian tube to head towards the surface, straightening the eustachian tube and sometimes solving problems underwater. This is a picture that I took when I was a fellow, and I always wanted to use it in a presentation. There's no relevance to this presentation. So decongestants are something that people use commonly, and their efficacy is sort of controversial. Quick-acting agents like Afrin possibly may have some slight benefit. Oral pseudoephedrine has been shown to help patients who are airplane passengers. Topical nasal decongestants such as Afrin, as I mentioned, have only slight benefit for hyperbaric oxygen. So their utility versus for diving is, a little bit equivocal, although it's widely used. If a patient's going to use nasal topical steroids, they certainly need to start several weeks in advance. So next we want to talk about our fitness to dive, because a large component of what's going to happen in your practice is you're going to hear from patients after they've had something happen, and they want to get back in the water as quickly as possible. And I usually use this analogy, and I think about it like this. So I remember my time in Los Angeles where you'd see a patient who has exostoses and they want to get back in the water as soon as possible. Well, dissuading them from surfing again is almost impossible. So historically, diving is very similar, and diving criteria has been super conservative. So generally, without data, we just say you can't dive. And so what we want to do is we want to look at this information on a case-by-case basis. One thing that can often be done in counseling, though, is you can actually tell patients to perform what's called a test dive, where they go to 2 to 3 meters of water and attempt to see how they do. And that's a good counseling technique. So let's talk next about eustachian tube dysfunction. If you have a significant eustachian tube dysfunction with sequelae such as fluid and effusion or a perforation, that's an absolute contraindication to diving. Chronic eustachian tube dysfunction, such as a history of ventilation tubes, is a relative contraindication. That's maybe something where you'd want to think about a test dive to see how patients do. One of the promises that we have with new technology is the concept of balloon dilation procedures. So there's some data actually out of San Diego from the military just in the last 2 years looking at the success of this procedure, and also some information, one paper from Israel as well, which we're not citing here. But the summary statement here is that with a pre-treatment symptom of 48 months, 12 out of 13 patients were able to return to their military duties, which included diving, with improvement of eustachian tube dysfunction, quality of life scores, with a mean duration of follow-up. And this is both divers and patients who are aviators. So there's possibly some utility from this new technology. The next discussion is the ear canal. So we've talked a little bit about complete stenosis or otitis externa. These are absolute contraindications. Generally speaking, if you can see the eardrum, you can dive. Moderate cerumen or mild exostoses would not be contraindications. A tympanic membrane perforation or a ventilation tube are absolute contraindications. As Dr. Mallen has said, this is the chance for a unilateral caloric response in an obligate mouth breather, which can be a catastrophic problem underwater, and also for the possibility of inducing waterborne pathogens. Alternobaric vertigo is not a contraindication. It's very common, and oftentimes this is an opportunity for improved autoinsufflation techniques and education. However, resolved labyrinthitis and vestibular neuritis should be considered as not contraindications. However, vestibular testing may be encouraged. If you have a patient with a cholesteatoma, they shouldn't die due to the possibility for a perforation or a perilymphatic fistula. Hearing loss or tinnitus established is not a contraindication, but I think you're going to see patients with single-sided deafness, and you have to have that conversation where you say, okay, well, you have one hearing ear. There is some relative risk here by diving with one ear. So I think that's an important concept. Now, when you look at implants, there's really no data on looking at bone-anchored hearing aids. And because of that, in our paper, we listed that as a relative contraindication. There's no data to suggest one way or the other. However, if you think about the mechanisms, it's probably fine, to dive with a BAHA in place, particularly these BAHAs now that are, the osseous device, which is completely under the skin. Cochlear implants are a slightly different story. There's the possibility for a PLF. Data suggests that in simulated hyperbaric oxygen pressure simulating 50 meters of depth, patients typically do fine. But there is a device warranty issue. So if a patient dives, they're out of luck if there's a problem underwater with a warranty. So cochlear implants, we call that a relative contraindication. Imbalance disorders such as positional dizziness, Meniere's disease, central disorders can be difficult underwater. And because, again, they're obligate mouth breathers, it should be, patients should be counseled accordingly.
So any condition that traps air in the sinuses and prevents equalization can cause barotrauma. That can be from frank polyposis or even just significant inflammation. Septoplasty and sinus surgery have good results for appropriate patients. Allergic rhinitis is often less of a problem at dive sites because they're typically in beautiful places with nice climates and low pollen counts from palm trees. Tracheostomy and laryngectomy are absolute contraindications. I hope I don't have to explain why to the group. The other laryngopulmonary contraindications are to spot on this list because they either restrict ventilation or oxygenation. It's worth specifically highlighting laryngocele. Before a laryngocele is repaired, it's a contraindication because air within it can expand on ascent and occlude the airway. The risk of recurrence even after treatment, though, necessitates continued monitoring in an active diver because diving itself can precipitate worsening secondary to increased intralaryngeal pressure and repeated Valsalva. A patient has to be able to maintain an oral seal around the regulator. A facial nerve palsy or prior oral surgery can be an impediment to this. You don't have to have teeth to use a mouthpiece, but you do have to be able to create a watertight seal. There's also a risk of expanding air, disrupting cavities, root canals, other dental work, but this really isn't a contraindication. Children represent a small but important subset of the diving population. It's important to remember that they're not just small adults and that some of the relative contraindications in adults are absolute contraindications in children. For example, a radical mastoidectomy and chronic sinusitis are considered absolute contraindications in this population. Kids have increased prevalence of adenoid hypertrophy, potentially blocking the torus tubarius, and their eustachian tubes don't reach adult dimensions until between really 7 and 10 years of age. Furthermore, children up to 12 are noted to occasionally have worse eustachian tube dysfunction than adults. So recommendations for kids involve making sure that they're not pressured to dive, that they're otherwise medically fit, that they dive to a max depth of 9 meters, that they're one-to-one with an instructor, and that they only dive in calm conditions without rescue responsibilities for the child. Fortunately, the most common issues related to diving are pretty easily treated. Otitis externa, for example, is very, very common, and the treatment is the same as normal standard practice. Similarly, sinus pressure and epistaxis are typically self-limited. Sinus barotrauma is often just supportive care and reassurance. If patients have upper respiratory infections, it may warrant antibiotics or decongestants, but really no different than any other patient who hadn't dove. Imaging or surgery is very rarely needed. The exceptions are in situations with concerning associated findings, such as ocular or mental status changes, gross deformity, or suggestion of a CSF leak. CSF leaks with diving present the same way as they do on land, so typically unilateral clear rhinorrhea with a salty taste that worsens with the Valsalva and is beta-2 positive.
So in terms of treatment classification for middle ear barotrauma, there is a classification system, which is essentially 1 through 5, extending from mild hyperemia to frank perforation. And treatment of middle ear barotrauma is largely supportive. So we can see, John, in the next slide, the sequence going from 1 to 5, and then in the next slide, the grading system. So really, in terms of treatment of middle ear barotrauma, it's largely supportive. Antibiotics are used really only in the case of waterborne antigens or bugs, pathogens. And you'd want to consider vestibular testing if there's been significant insult, possibly serial audiograms, and non-supportive, and then also supportive care. So one important point is describing the difference between inner ear barotrauma and inner ear barotrauma and inner ear decompression sickness. And the two of these entities can be deciphered based on history and clinical exam findings. It's really uncommon for them to occur concomitantly, but they have some of the same symptoms. So inner ear barotrauma most commonly occurs during descent. This can occur at any depth. And oftentimes you'll see a perforation of the tympanic membrane or hemotympanum associated with otalgia, and you'll see maybe a Tullio or a Henneberg sign if you have a PLF. Where decompression sickness occurs on ascent only, and after ascent, and usually occurs sometime after they've come out of the water. And patients will be confused, they'll have altered mental status. Then there's also a pathognomonic hematological manifestation, which we'll show you in a second, which is actually kind of rare. So, differentiating these two entities is important. This is the, in the next slide is the pathognomonic skin manifestation. This is called cutis marmorata, which you can see in some patients who have had decompression sickness. So treatment of inner ear decompression sickness is immediate hyperbaric oxygen when possible, and when not possible, high flow normal baric oxygen should be utilized. And patients typically do well, and the sooner they get this treatment, the better that they'll do. Steroids for these patients, this seems to be unproven. For inner ear barotrauma, it's largely supportive. So an audiogram can be utilized with vestibular testing if there's any concern for vestibular hypofunction, but generally patients should avoid maneuvers that increase intracerebral spinal fluid pressure, such as the Valsalva. If you have a suspicion for a PLF, such as in the case of a positive fistula test, you'd want to undergo consideration of that, and that's done by two ways. One, there's two schools of thought. One is a conservative school where you essentially watch these patients, conservatively manage them in 5 to 10 days, or immediate surgical exploration. And that would be considered in fluctuation or progressively deteriorating hearing. There's really no great data on diving and PLF fistula repairs. However, one study by Park et al. Looked at better outcomes for early surgical intervention in a patient series of about 20 patients. However, those patients did not undergo surgery for diving-related trauma. There's a Divers Alert Network, which is very useful for identifying the availability of hyperbaric oxygen chambers locally, and also for guidance for physicians. We just like to identify that for you all. So again, one of the major things that we have to discuss is the question of when you can go back to dive. And this is the question that patients are going to have. So after ear injuries such as middle ear or inner ear barotrauma, this is not inherently a contraindication to returning. Traumatic perforation should be repaired. Peripheral vertigo should be assessed if that's visualized. And also should be noted that in a case series of 20 patients by Parnell and Becker, with patients who experienced this, if they were taught the appropriate ways to clear their ears, they were able to return to diving without any sequelae. Inner ear decompression sickness is slightly more controversial and less promising. So many patients, approximately a quarter, still have symptoms after 3 months after their injury.
All right, so in terms of decompression sickness, there are two main guidelines that are utilized in determining return to diving timelines. The US Navy has much more forgiving criteria, but more conservative measures for recreational divers are honestly appropriate, given that civilians don't have the same imperative to return to diving. Patients with a severe or recurrent neurologic decompression sickness are sometimes referred for echocardiogram to assess for a patent foramen ovale. Despite the connection between large PFOs and inner ear decompression sickness, though, PFOs are really common in the general population, and many patients with decompression sickness don't have a PFO, suggesting that closure may not even prevent future incidents. While there are cardiothoracic surgeons who tout that they have performed these successfully and let people get back in the water, the serious adverse event risk is 1% for closing a PFO, which is an entire order of magnitude larger than the risk of decompression sickness itself. So as a result of that, closure really should not be considered required treatment, particularly given the ability to reduce the risk of recurrent decompression sickness by altering diving depths going forward.
So what about after ear surgery specifically? Tympanoplasty, after the eardrum is healed, it's okay to return to the water. When you talk about prostheses such as a PORP, generally it's accepted that you can dive with a PORP in place. A TORP is a little bit different, more controversial, and Society for Diving and Hyperbaric Medicine and Professional Association of Diving Instructors consider an absolute contraindication. However, others suggest that a provocation test, where essentially you do a tympanogram with an audiologist and you monitor for vestibular symptomatology, that can be performed, and possibly with a pool dive, to determine your candidacy moving forward. Stapedectomy is also a different story. Historically, this has been discouraged. Actually, Dr. Antonelli performed an animal model study suggesting it was safe. And actually, Dr. House in the early 2000s looked at the House Clinic database, and they found a series of, it was a couple thousand patients, where they performed a study where they actually sent questionnaires and asked if patients had died, and they identified a series of patients who had dove after stapedectomy, and none of whom had sequelae from their diving. So the conclusions there were, maybe this is safer than we think it is. I think it still merits a conversation of the possibility of a problem. But you know, I think the data is open-minded about diving after stapedectomy.
So there's no hard and fast rules regarding return to diving after sinus surgery. If you're doing a septorhino, you have osteotomies, you want to give it 6 weeks to heal, just because the face mask puts pressure on the nasal bones. After sinus surgery, the risk of sinus pressure is largely mitigated if the natural drainage pathways were opened. The big risk is if you had a crack in the lamina pepratia or an unappreciated skull base injury. As long as the area is remucosalized, though, the risk of orbital emphysema is very low. Skull base defects, when they're repaired, are theoretically allowable. However, there's no prospective data, and no one really knows exactly which patients will have an issue. There have been some case reports of barotrauma-induced pneumocephalus after skull base surgery, in patients who flew on airplanes, as well as reports of pneumocephalus after diving, even in the absence of a known defect or prior surgery. But from a theoretical perspective, there's no specific reason why patients shouldn't be able to dive after skull-base surgery. And there is evidence showing that patients who have had complex craniofacial reconstruction do just fine. All right, so bringing it in the home stretch. So scuba diving is risky by nature. We can't guarantee a dive will be injury-free any more than we can guarantee that the patient will have a good surgical outcome or that they'll be able to drive safely to the hospital. With proper counseling and good technique, we can limit that risk. As we amass more data on diving, we can continually shift from precautions based on theoretical risk to calculated decisions based on evidence. Diving candidacy can be graded. The pool is an excellent option to simulate the pressure experienced during a dive. A return to diving at shallower depths only can be a more realistic alternative than total cessation. Audiogram and imaging are occasionally helpful, but the vast majority of acute injury doesn't require any adjuvant testing. And finally, scuba diving is an awesome experience. It's a window into a whole new world right at our fingertips. It's as close as most of us will ever come to exploring outer space, and frankly, we can't recommend it highly enough.
Hello, my name is Dr. Kevin Peng, neurotologist here at the House Institute. Thank you for watching this video. The House Institute provides free educational videos for hearing health professionals worldwide. To help support videos like these and other educational efforts, please consider donating by clicking the link in the description box below. Your generous support allows us to keep videos like these at no cost for you and others. Thank you.